really, to understand sodium and water imbalances, you just have to understand some basic principles. And the biggest one is where salt goes, water follows. So where salt goes, water follows. Because sodium requires active transport to cross membranes, you really have to think about this material in terms of concentrations, and really water concentrations. You typically don't have a sodium issue. You typically actually have a water issue. So in order to adjust from the intracellular fluid to the extracellular fluid, the water actually has to move between those spaces. It can range from asymptomatic to life-threatening, and the number one symptom associated with both hypo and hypernatremia are neurologic symptoms. Neurologic symptoms because of the swelling or shrinkage of the cells in the brain due to that shift of fluids. They can result from diseases, chronic diseases, acute illnesses. They can also be drug-induced. We think about diuretics sometimes when we think about sodium wasting. And it's also very important to understand, what caused your sodium and water disorder so you can correct it appropriately. So total body water, we have to think about in terms of where the fluids are versus where the sodium is. Total body water, and it's split between the intracellular fluid and the extracellular fluid. So the intracellular fluid takes about 2/3 of the total body water, and you're talking about the fluid contained within the cells. Fluid contained within the cells, which is where most of your potassium, magnesium, and phosphate live. Your extracellular fluid, which is where we're going to focus a lot on today, is only about 1/3 of the total body water, and that's the fluid outside the cells. So that's your serum and then your interstitial space. The homeostasis of the ICF, the intracellular fluid, and the ECF, the extracellular fluid, is maintained by the sodium potassium ATPase pump, which means that sodium cannot freely cross the cell membrane. And because sodium is the primary establisher of tonicity or osmolality, we're going to use those interchangeably, of the ECF, what happens is water actually has to move. So where salt goes, and that's going to be placed in the body via some sort of active mechanism, usually by mouth, water will follow. And remember that water moves freely between the ECF and the ICF, and that's how you're going to achieve equilibrium. So we're going to start with hyponatremia. It is probably the most common electrolyte disorder in any patients, and it's technically defined as a serum sodium less than 135. So in acute hyponatremia, we're talking about large sodium decrease in less than 48 hours, usually large symptoms, a good amount of symptoms, especially when we get below 120. And these are the patients that we have to be careful when we're fixing, but they're also the ones that we have to be a little bit more aggressive with. So in the 130 to 135 range, we typically don't see any symptoms, and that's regardless of whether it's acute or chronic. 125 to 129, we may start seeing some symptoms. They're very non-specific. It's very hard to relate them back to the hyponatremia. We may just give them a little bit of fluid, depending on whether they're volume depleted or volume overloaded, and should be able to fix that with minimal concern. When we start getting below 125, that's when we start seeing actual symptoms that we can infer are related to our hyponatremia. So we can get headaches, nausea, vomiting, muscle cramps, and confusion. And when we start seeing that confusion, that's when we start to worry. That's when we start to worry that we've started to get some cerebral edema. And then less than 120, we're going to start seeing, we can see brain damage, we can see coma and death. So it's very important once we see our sodium level less than 120 that we act pretty immediately. For chronic hyponatremia, that cutoff is still 48 hours. It is a consistently decreased sodium for over 48 hours. A lot of our elderly patients are going to fit into this category. The brain typically adapts in these patients to protect against cerebral edema. So they are much less likely to be symptomatic. However, because of the symptoms, because of the lack of symptoms typically, they're at a higher risk of overcorrecting. But the biggest thing that we have to worry about when we're talking about treating hyponatremia is osmotic demyelination syndrome, or central Pontine myelinolysis. Central Pontine myelinolysis, and that is a symptom, a very severe symptom or complication of overcorrecting the sodium. When that happens too fast, those cells are going to shrink and they can hemorrhage. So that's a very important concept to understand, how the water moves in relation to the sodium concentration. So patients are at severe risk for central Pontine myelinolysis if they've been chronically hyponatremic, if they're elderly, if they're alcoholics. The worst thing is that it's irreversible, and you may not see the effects immediately. So you may not see the effects immediately, but those patients are going to have seizures, altered mental status, dysarthrias, dysphasias, serious and irreversible brain damage.